Good afternoon, everyone. My today's presentation regarding endocrine mucinous gland carcinoma of eyelid, a case series of rare presentation. Endocrine producing sweat gland carcinoma is a rare tumor of sweat gland origin with a predilection of for the eyelid and periocular skin of elderly females. Histopathologically, it is a low-grade neuroendocrine neoplasm and the cutaneous analogous of solid papillary adenocarcinoma of the breast. The carcinoma is under recognized low-grade sweat gland carcinoma and pursues indolent course and a favorable prognosis. To the best of our knowledge, about 80 cases of endocrine mucinous producing gland sweat gland carcinoma of eyelid reported till date in English literature. And here we present the 3 patients of endocrine mucinous gland carcinoma from the Indian subcontinent. First case of a 65-year-old male patient with the mass of left lower eyelid that was painless and gradually increasing in size, and patient has history of the sty 4 months back at the same site. The complete medical examination and the past medical family history was noted unremarkable and no lymph nodes were palpable. On clinical examination, the mass was firm, non-tender, lobulated with loss of eyelashes, which was involving lower punctum and approximately 3.5 into 2.5 into 1.5 centimeter square in size. There was no restriction in ocular movements and no proptosis or lymphadenopathy was noted. Anterior segment and fundus were within normal limit. Left eye lower lid wide local excision with 4 mm margin clearance was performed. At the 6 month of follow-up, patient was asymptomatic and no recurrence was noted. On histopathological examination, on microscopic examination, pale and pink cytoplasm was noted. There was a microcystic floating tumor cells in copious mucinous material. Mitotic figures were infrequent. And the final, on the basis of morphology, diagnosis of a malignant skin adnexal tumor favoring endocrine mucin producing sweat gland carcinoma. On immunohistochemical analysis, the tumor cells were stained positively for cytokeratin 7, A1, synaptophysin, NSE, and ER. Chromogranin is focal positive. CK20 and P63 were negative for this tumor. So the final diagnosis was endocrine mucin producing sweat gland carcinoma of eyelid was made. The second case was the 68-year-old male patient with the same complaint, painless and gradually increasing in size mass of the right eye. On clinical examination, firm non-tender lobulated mass near lateral canthus of right eye, which was 1.7 into 1.2 into 0.6 centimeter. There is no restriction of ocular movements, no proptosis. Lymphadenopathy was noted in bilateral level 1B and 2 on USG, which was suggestive of a benign nodes. Anterior segment and fundus within normal limit. Right eye lower lid wide local excision with 4 mm margin clearance was done. On histopathology examination, multiple nest of lobules tumor cells arranged with a solid cribriform adenoid pseudopapillary pattern surrounded by mucin, with evidence of pool of mucin containing floating nest cell of tumor cells, which was round, ovoid, basaloid, nucleus stippled, and vesicular nuclear chromatin conspicuous nuclei and minimal pleomorphism was noted. Overall finding suggestive of malignant skin adnexal tumor, possibly that was endocrine mucin producing sweat gland carcinoma. And on immunohistochemical analysis, positive for CK7 and synaptophysin was also positive. CK20 and P63 was negative. The third case was 72-year-old male patient came with a mass of left upper eyelid which was painless and gradually increasing in size. Complete medical examination, past history and family history is unremarkable. On clinical examination, firm non-tender lobulated mass which was with loss of eyelashes was present. The mass was approximately 1.8 into 1.5 into 1.08 centimeter. No restriction of eye movements, no proptosis, no lymphadenopathy was noted. Anterior segment and fundus are within normal limit. Left eye upper lid wide local excision with 4 mm margin clearance with upper lid reconstruction was performed in this patient. On histopathology examination, squamous epithelial with multiple nests and lobules of tumor cells arranged in white with solid cribriform pseudoglandular pattern floating in pool of extracellular mucin separated by fibrous septa. Tumor cells were round ovoid basaloid nuclei with eosinophilic cytoplasm and minimal pleomorphism. Overall findings suggestive of mucinous carcinoma of left upper lid. All margins were free from tumor cells. Endocrine mucinous gland carcinoma of eyelid is a rare malignancy with histopathologically features resembling both mucinous carcinoma and endocrine ductal differentiation. First first described in extracutaneous sites such as breast and GIT, and also that was misdiagnosis as cyst, calagion or basal cell carcinoma. The occurrence in the eyelid poses diagnostic and management challenges due to its subtle clinical appearance and potential for local recurrence and regional spreads. In this case series, we have reported 3 patients diagnosed endocrine mucinous carcinoma with surgical excision with wide margin remains the mainstream of this patient, and all patients are positive for CK7 and chromogranin and synaptophysin. This case series contribute the limited literature on endocrine mucinous gland carcinoma of eyelid and highlights the need of high index of suspicion, surgical planning and long-term follow-up given the potential recurrence and rare metastasis. And it is approach involving the both oculoplastic and oncologist expertise. Okay. The conclusion is the endocrine mucinous gland carcinoma of eyelid is a rare malignancy that can mimic both lesions leading to delayed diagnosis. Wide local excision with clear margin is essentially to prevent recurrence. Early diagnosis and long-term follow-up are the key for the optimal outcome. Thank you, sir.
Thank you. What the medical treatment you have given after excision?
After excision, we can give the local antibiotic treatment, and if the sample was sent for the histopathological examination, after histopathology examination, we send the patient's slide for immunohistochemistry if the suggestion was exactly about the endocrine mucinous gland carcinoma.
Any preventive measure for
The recurrence is there. It is the malignant tumor, but there is no metastasis is noted yet. So we can observe the patient in follow-up. If there is a recurrence, the same treatment we can wide local excision was performed.
Did you gone for metastasis study?
Yes, sir. Yeah, we can go for the USG neck lymphadenopathy. If there is any lymphadenopathy was noted, we can work up for the metastasis for the patient. Any cancer.
Okay, thank you.
Thank you.